Welcome back to the MedPod. We've got a really interesting deep dive for you today from a paper someone sent in called Biometrics Say.pdf. Yeah, the title isn't the most appealing, but
It's not exactly catchy.
yeah, but the content is really fascinating. We're going to be
All
talking
right.
about biostatistics in medicine.
And you're right, the title doesn't exactly scream excitement,
Right.
but
Yep.
understanding biostatistics is truly crucial for anyone involved in medicine, whether you're a student or a researcher or even a practicing clinician.
Okay, so before we get too far, let's unpack this for our listener.
Right,
Imagine you're a doctor and you're trying to figure out whether to prescribe a new drug to your patient.
right.
We've seen some promising research, but you really need to understand the data to make a good decision.
That's exactly where biostatistics comes in. It gives us the tools to analyze data, evaluate the evidence, and make sound judgments about diagnoses, treatments, and even preventative measures. And this paper that you have is a fantastic overview of the key concepts.
All right, let's dive into the paper then. The first thing that really jumps out at me is this idea of probability. It seems like it's the foundation of everything in biostatistics.
It absolutely is. In medicine, we're constantly dealing with uncertainty. Is this patient's chest pain because of a heart attack or something less serious?
Right.
Will this antibiotic even be effective against this particular infection? Probability really helps us quantify that uncertainty and make more informed decisions.
So it's not just about some abstract number, it's about real-world decisions that impact patients' lives. Could you give us like a specific example of how probability plays out in a medical setting?
Sure, let's take the example of diagnosing a disease. No diagnostic test is ever perfect. There's always a chance of false positives and false negatives. Understanding the probabilities associated with a particular test helps us interpret the results accurately and avoid making the wrong call.
That makes total sense. So if a test has a high probability of a false positive, we might want to be cautious about interpreting a positive result
Right.
and consider further testing.
Exactly. Now, the paper goes on to discuss different types of probability distributions, and these are essential for understanding how data is spread out and what's considered normal or unusual.
Oh,
For instance, think about blood pressure readings. They tend to follow a normal distribution, meaning most people fall within a certain range with fewer people at the extremes.
the famous bell curve. I remember that from stats class. So knowing the distribution of blood pressure can help us determine what's considered high or low.
Yeah, precisely. And the paper gives some really great examples of different distributions and how they apply to various medical scenarios. For instance, you might see a Poisson distribution used to model the number of patients arriving at the emergency room on a given day.
Okay, so we've got probability distributions. What's the next key concept we need to know?
Before we jump into specific statistical tests, the paper emphasizes the importance of thinking like a statistician. It's not just about plugging numbers into formulas, it's about understanding the principles of data collection analysis and interpretation.
Thinking like a statistician. What does that even mean in medicine?
It means being aware of potential biases, understanding the limitations of data, and being able to draw valid conclusions from the evidence. For example, let's say you're reading a study about a new surgical technique. You need to consider the sample size, the study design, and potential confounding factors to determine whether the results are truly applicable to your patients.
So it's about looking beyond the headlines and really digging into the details to make sure the evidence is solid. Could you maybe give us an example of a potential bias we might see in a medical study?
Sure. Selection bias is a common one. Imagine a study on a new weight loss drug that only recruits participants who are highly motivated to lose weight. The results might show impressive weight loss, but they wouldn't necessarily be generalizable to the wider population.
That's a great example. It highlights how important it is to critically evaluate the methods used in a study before accepting the conclusions. Now, the paper also talks about different types of data. And to be honest, sometimes I get those confused. Can you give us a quick refresher on qualitative versus quantitative data?
Of course, think of qualitative data as descriptive data. It's about qualities or characteristics or categories that can't easily be measured with numbers. For instance, a patient's medical history, the types of symptoms they're experiencing, or their overall satisfaction with the treatment would fall under qualitative data.
Okay, so it's like painting a picture with words, right?
Wow.
What about quantitative data? That's the one with all the numbers, right?
Exactly. Quantitative data is all about measurements and numbers. It could be a patient's blood pressure, reading their temperature, their white blood cell count, or even the duration of their hospital stay. And there are different types of quantitative data as well.
Oh, right. I remember learning about continuous and discrete data. Can you remind us what those are?
Absolutely. Continuous data can take on any value within a certain range. Think about like height, weight, or blood sugar levels. Discrete data, on the other hand, can only take on specific values.
Yeah.
It's often used for things we count, like the number of pregnancies a woman has had or the number of times a patient has been admitted to the hospital.
Okay, so understanding the type of data is crucial because it determines how we analyze it and what kinds of statistical tests we can use.
You got it. And the paper does a great job of explaining how different types of data are visually represented in charts and graphs. Being able to interpret these visual representations is essential for making sense of research findings and understanding patterns in data.
All right, so we've got probability distributions, types of data, and the importance of thinking like a statistician. It feels like we're building a solid foundation here. What's the next layer of this statistical house we're constructing?
Now we're getting into the realm of specific statistical tests. The paper provides a comprehensive overview of commonly used tests, starting with the famous t-test. It's a workhorse in medical research used to compare the means of two groups.
The t-test. I
Yeah.
remember vaguely encountering it in my studies.
Right.
Can you refresh our memory on when we'd use a t-test and what it actually tells us?
Sure. Let's say you want to compare the effectiveness of two different pain relievers.
Okay.
You'd randomly assign patients to receive either drug A or drug B, and then measure their pain levels after a certain period. A t-test would help you determine whether there's a statistically significant difference in pain relief between the two groups.
So it helps us figure out if the difference we're seeing is real or just due to chance. But
Yeah.
the paper mentions different types of t-tests.
Right.
When would we use one type versus another?
That's a great question. The choice depends on the specific research question and the nature of the data. For instance, if we're comparing the blood pressure of the same group of patients before and after a treatment, we'd use a paired t-test. If we're comparing two completely different groups, like men and women, we'd use an independent samples t-test.
Okay, so choosing the right t-test is like choosing the right tool from a toolbox.
Right.
We need to know what we're trying to accomplish before we grab the hammer or the screwdriver.
Exactly.
Now, the paper also mentions ANOVA, which sounds pretty intimidating. What's that all about?
ANOVA stands for Analysis of Variance, and it's used when we're comparing the means of more than two groups. Imagine you're studying the effects of three different types of exercise on blood sugar levels. ANOVA would allow you to analyze whether there are any statistically significant differences between those three exercise groups.
That's really useful. So instead of doing multiple t-tests, we can use ANOVA to compare multiple groups at once. But how does ANOVA actually work? It sounds like some complex mathematical magic.
It's actually quite intuitive. ANOVA examines the variation in the data both within each group and between the groups. If the variation between the groups is significantly larger than the variation within the groups, it suggests that something more than just random chance is driving those differences.
So it's like looking at the signal-to-noise ratio.
Uh-huh.
If the signal of difference between the groups is strong enough to overcome the noise of individual variation within the groups, then we can be more confident that the differences are real.
Exactly. And if ANOVA tells us there's a significant difference, we can then use post-hoc tests to pinpoint exactly which groups are different from each other.
It's a two-step process. First, we see if there's a fire, then we investigate where the hot spots are. Now, the paper also delves into the world of confidence intervals, which always seem to be paired with those p-values. Can you remind us what confidence intervals are all about and why they matter?
Confidence intervals give us a range of plausible values for the true population parameter we're interested in. For example, let's say a study finds that a new drug reduces blood pressure by an average of 10 points. A 95% confidence interval might tell us that the true reduction in blood pressure for the entire population is likely between 8 and 12 points.
So instead of just giving us a single point estimate, it gives us a range acknowledging that there's always some uncertainty in our measurements.
Right.
And the narrower the confidence interval, the more precise our estimate is right.
Exactly. And confidence intervals can also help us interpret p-values. If the confidence interval for the difference between two groups doesn't include 0, it suggests that the difference is statistically significant.
Okay, so confidence intervals and p-values work together to give us a more complete picture of the data. Now, one thing that's always emphasized in statistics is the difference between correlation and causation. Can you remind us why that distinction is so crucial in medicine?
Absolutely. Just because two variables are correlated doesn't mean one causes the other. There could be other factors at play, those confounding variables we talked about earlier.
Can you give us a medical example of this correlation versus causation trap?
Sure. Imagine a study finds a correlation between ice cream sales and the number of drowning deaths. Does that mean eating ice cream causes people to drown?
No.
Of course not. The lurking variable here is likely hot weather. People eat more ice cream in the summer, and they're also more likely to swim, which unfortunately leads to more drowning incidents.
That's a classic example, and it highlights how important it is to think critically about the data and not jump to conclusions about causation just because we see a correlation.
You've got it. Correlation can be a clue, but it's not enough to establish causation. We need carefully designed studies to tease apart those relationships.
Okay, so we've covered a lot of ground already. Probability distributions, types of data tests, ANOVA, confidence intervals, and the ever-important distinction between correlation and causation. What's next on our statistical adventure?
Now let's delve into a critical aspect of medical testing:
Okay.
sensitivity, specificity, and predictive values. These concepts help us understand how well diagnostic tests perform.
I've heard those terms before, but I often struggle to remember what they mean. Can you break them down for us using a real-world example?
Imagine we have a test for a particular disease, let's say strep throat.
Okay.
Sensitivity tells us how good the test is at correctly identifying people who actually have strep throat. It's like the test's ability to catch all the true positives.
So a highly sensitive test is like a skilled detective who doesn't let any guilty suspects slip through the cracks.
Exactly. Now, specificity is about the test's ability to correctly identify people who don't have the disease. It's all about avoiding false positives.
So a specific test is like a discerning judge who doesn't convict innocent people.
Perfect analogy. Now, predictive values take things a step further. They tell us the probability that a person actually has or doesn't have the disease based on their test result. Positive predictive value is the probability that someone who tests positive actually has the disease.
So if a test has a high positive predictive value, we can be more confident that a positive result truly means the person has the disease.
Precisely. And negative predictive value is the probability that someone who tests negative truly doesn't have the disease. These concepts are crucial for both doctors and patients to make sense of test results and make informed decisions about healthcare.
This is all making a lot more sense now. We've covered so much ground, from the basics of probability to the complexities of diagnostic testing. I'm feeling much more equipped to navigate the world of medical data.
Me too. But before we wrap up this part of our deep dive, it's important to acknowledge that not all data fits neatly into those statistical boxes we've discussed.
Right.
Sometimes we encounter data that doesn't meet the assumptions of those traditional tests.
Yeah.
And that's where non-parametric tests come in.
Ah, yes. The paper briefly touched upon those. What exactly are non-parametric tests, and when would we use them?
They're statistical tests that don't rely on assumptions about the underlying distribution of the data. They're particularly useful when we have small sample sizes, when the data is not normally distributed, or when we're dealing with ordinal data where there's a natural order, but the intervals between categories aren't equal.
Can you give us some examples of these non-parametric heroes?
Sure. The Wilcoxon signed rank test is a non-parametric alternative to the paired t-test, and it's used to compare two related samples. The Mann-Whitney U-test is a non-parametric counterpart to the independent samples t-test, and is used to compare two independent groups.
So it's like having a backup plan when our traditional statistical tools don't quite fit the job.
Exactly. Non-parametric tests give us more flexibility in analyzing data that doesn't conform to those strict assumptions, and they can be just as powerful in helping us draw meaningful conclusions.
This has been a fantastic overview of the foundations of biostatistics. We've covered so much ground, from probability and distributions to hypothesis testing and diagnostic testing. I'm feeling much more equipped to navigate the world of medical data now.
Me too. But before we wrap up, it's important to acknowledge that biostatistics is a constantly evolving field. With the rise of big data and artificial intelligence, there are even more exciting developments on the horizon.
That's a great point. But before we get carried away with the future, I think we've given our listener plenty to digest for now. We've laid a solid foundation and explored some of the key concepts and tools of biostatistics. When we return, we'll delve deeper into some of those specific statistical tests and see how they're used in real-world medical research. Stay tuned.
Okay. Welcome back to the MedPod. Before we took a pause, we were really laying that groundwork, exploring the essential concepts of biostatistics.
Right.
Now let's actually put those concepts into action and delve into some specific statistical tests in a bit more detail.
I'm ready to roll up my sleeves and get into the nitty-gritty. One of the tests you mentioned before our break was analysis of variance, or ANOVA. It sounds a bit like a high-tech kitchen appliance.
Well, it's definitely a powerful tool in our statistical kitchen. ANOVA really shines when we're working with more than two groups. And we're trying to figure out if there are any statistically significant differences between their averages.
Okay, so instead of just comparing Group A to Group B,
Yeah.
we might have a whole potluck of groups A, B, C, and maybe even D.
Precisely. Imagine you're a cardiologist and you're researching the effects of different diets on cholesterol levels. You might have one group following a Mediterranean diet, another on a low-carb diet, and a third group continuing their usual diet.
Okay.
ANOVA would be your go-to analysis to see if there are any significant differences in cholesterol levels between those three diet groups.
That's a great example. It helps me visualize how ANOVA could be used to compare the effectiveness of different interventions or treatments. But what are we actually looking for when we run an ANOVA? What's the smoking gun, so to speak?
We're essentially looking for clues in the variation of the data.
Okay.
ANOVA examines how spread out the data is within each group and compares it to the spread between the groups.
Right.
If the variation between those diet groups is significantly bigger than the variation within each group, it suggests that there's something more than just random chance causing those differences.
So it's like comparing the impact of the diets themselves to the natural variation in cholesterol levels that we'd expect to see even within a group of people eating the same things. We want to see if the diet signal is strong enough to rise above the background noise of individual variation.
That's a fantastic way to put it. And if ANOVA gives us a red alert telling us there's a statistically significant difference, we can then use post hoc tests to pinpoint exactly which groups are different from each other.
It's like a detective using a metal detector to find buried treasure. First, the detector beeps, indicating something's there. Then you have to dig down to see what you've actually found. So ANOVA is our metal detector for multiple group comparisons.
I like that analogy. Now, what about those situations where we're only working with two groups? Before the break, we talked about t-tests, and I'm still a bit fuzzy on when we'd use one type of t-test over another. It's like having different wrenches for different size nuts and bolts.
You're reading my mind. I'm ready to get those t-tests sorted out. Let's break them down one by one, starting with the simplest scenario.
All right, let's start with the one-sample t-test. It's our go-to when we want to compare the average of a single group to a known value. It's like checking if a batch of cookies is baked to the right temperature according to the recipe.
So something like comparing the average height of kids in a school to the national average height for their age group.
Exactly. Or we could use a one-sample t-test to compare the average blood pressure of patients before they start a new medication to the target blood pressure we're aiming for.
Got it. So one-sample t-tests are for those head-to-head matchups with a known standard. What about those situations where we're comparing two groups, but they're not independent of each other? You mentioned something called a paired t-test before the break. Is that where this comes in?
Precisely. A paired t-test is our tool of choice when we're comparing the same group of individuals at two different points in time.
Okay.
It's especially useful when we're evaluating the effectiveness of a treatment or an intervention, like tracking weight loss on a new diet plan.
So if we're studying the effects of a mindfulness program on anxiety levels, we'd use a paired t-test to compare participants' anxiety scores before and after the program.
Exactly. We're essentially looking at the changes within each individual.
Okay.
Rather than just comparing the overall averages of the two groups, it helps to control for those individual quirks and variations that might muddy the waters.
It's like we're using each person as their own control, right? We're seeing how they change over time rather than just lumping them into a big pot and stirring.
That's a great way to think about it. And finally, we have the independent samples t-test. This one steps in when we want to compare the means of two groups that are independent of each other, like comparing apples and oranges.
Okay, so if we were comparing the effectiveness of two different types of physical therapy for back pain, we'd randomly assign patients to either therapy A or therapy B, and then use an independent samples t-test to see if there was a significant difference in pain relief between the two groups.
You nailed it. In this case, the groups are independent because what happens to someone in Group A has no bearing on someone in Group B. We're trying to determine if the difference we see is due to the type of therapy itself or just random chance.
So it's like having two ships sailing on different seas. We want to see if their courses diverge because of something inherent to the ships themselves or just because of the random waves and currents they encounter along the way.
I love that analogy. Now, remember those non-parametric tests we mentioned earlier? They're like our life rafts when the seas get rough and the assumptions of our traditional tests start to spring leaks.
You're right. It's time to pull out those life rafts and see what they can do. Can you remind us what makes these non-parametric tests so special?
There are trusty companions when those assumptions of normality and equal variances, those calm seas we rely on for our parametric tests, go out the window.
So it's like having a backup plan for when our data is a bit unruly, right?
Exactly. Remember those parametric tests we've been talking about, t-tests and ANOVA?
Yeah.
They work best when our data is normally distributed, meaning it follows that classic bell-shaped curve, but sometimes our data might be skewed, have outliers, or come from small sample sizes, like a ship sailing through a storm. And that can really mess with the accuracy of those parametric tests.
It's like trying to sail a luxury yacht through a hurricane, not the best idea.
Precisely. And that's when those non-parametric tests sail in to save the day. They're more like sturdy, rugged tugboats. They're not as flashy or fast, but they can handle rougher seas and less predictable data.
Okay, I'm starting to see the appeal. Can you give us a medical example of when we might need to send out an SOS for those non-parametric reinforcements?
Absolutely. Let's say you're a psychiatrist studying the effects of a new therapy on patients with severe depression.
Okay.
You're measuring their depression symptoms using a standardized scale. But the data is pretty messy. Some patients experience dramatic improvements, others show little change, and a few might even worsen. This kind of data often doesn't follow a normal distribution, and using a parametric test like a paired t-test could give you misleading results.
So in this case, we'd want to use a non-parametric test because it's less sensitive to those extreme values and doesn't rely on the data following a perfect bell curve.
Exactly. A non-parametric test like the Wilcoxon sign rank test would be a much better choice here. It's less about precise numerical averages and more about comparing the overall rankings or positions of the data points.
So it's like judging a diving competition. We're not just looking at the specific scores each diver gets, but we're also considering their overall ranking relative to the other divers. Even if one diver has a spectacularly high score on a single dive, they might not win if their other dives are less impressive.
That's a great analogy. And that's one of the strengths of non-parametric tests. They're often more robust, meaning they're less affected by those outliers or quirks in the data that can throw off our parametric tests.
That's reassuring. It's like having a statistical safety net for those times when our data is being a bit of a rebel. But I have to ask, if non-parametric tests are so flexible and robust, why don't we just use them all the time? What's the catch?
That's a great question. While non-parametric tests have their advantages, they're not always the best tool for the job. Generally speaking, they tend to be slightly less powerful than their parametric counterparts when the data actually is normally distributed. They're like those sturdy tugboats we talked about. They can get the job done, but they might not be as speedy or efficient as a sleek sailboat when conditions are ideal.
So it's like choosing between a powerful sports car and a reliable all-terrain vehicle. If you're driving on a smooth paved highway, the sports car will get us there faster. But if we're venturing off-road into unpredictable territory, the all-terrain vehicle is the more sensible choice.
Exactly. We need to weigh the trade-offs and choose the statistical vehicle that best suits the terrain of our data.
This has been incredibly helpful in demystifying those statistical tests.
Good.
I'm starting to see them not as intimidating equations, but as powerful tools for navigating the often messy world of medical data.
That's fantastic to hear. We've covered a lot of ground here, from basic concepts to specific statistical tests.
Yeah.
But the real magic happens when we apply these tools to real-world medical problems. When we come back, we'll explore some fascinating examples of how biostatistics is used to make a difference in patients' lives.
Welcome back to the MedPod. We've spent the last two segments building our statistical toolbox, exploring everything from basic probability to those workhorse statistical tests like t-tests and ANOVA.
Right.
Now I'm excited to see these tools in action.
Me too. I think our listeners will be amazed by how much biostatistics impacts their daily practice, even if they don't realize it.
Let's start with something I know our listeners encounter all the time, medical research articles. It seems like every week there's a new study making headlines.
Ow!
How can our listeners use their biostatistics knowledge to read these articles with a more critical eye?
That's such a great point. Biostatistics helps us sift through those headlines and get to the heart of the matter. Is this research truly relevant to my patients? The paper you sent in actually highlights a classic statistical trap.
Yeah.
Confusing correlation with causation. Just because a study finds a link between two things doesn't mean one causes the other.
Can you give us an example that would really hit home for our listeners?
Imagine a study that finds a strong correlation between owning a pet cat and having fewer heart attacks.
Okay.
Intriguing, right? But before we all rush out to adopt a furry friend, we need to think critically.
Maybe people who own cats are just more relaxed. Or maybe they tend to be more active because they're playing with their pet. There could be so many other factors at play.
Exactly. That's where those confounding variables we talked about earlier come in. It's the job of the researchers and the savvy reader to try to untangle these potential explanations and not jump to premature conclusions.
So correlation can be a starting point, a clue to investigate further, but it's not the finish line.
Absolutely. Now, the paper also dives into another key concept that helped us evaluate research:
Okay.
statistical versus clinical significance. A study might show a statistically significant result, a p-value less than 0.05,
Right.
but that doesn't always mean the findings are clinically meaningful.
So it's like the difference between finding a tiny gold nugget and striking a massive gold vein.
Yes.
Both are gold, but the impact is quite different.
I love that analogy. Let's say a study finds a new drug lowers blood pressure by an average of 2 points. Statistically significant? Maybe. Clinically significant? Probably not. It's unlikely to make a noticeable difference in a patient's overall health.
So we need to consider both statistical and clinical significance when deciding if a study's findings are worth changing our practice over.
Exactly. And remember those confidence intervals we discussed.
Yeah.
They're like a measuring stick for precision.
Right.
The narrower the interval, the more confident we can be about the true effect.
Okay, so let's put this all together. Our listener is reading a research article about a new treatment for migraines. What are the key things they should look for to critically evaluate the findings?
First, they should check the study design. Is it a randomized controlled trial considered the gold standard in research? Next, they need to look at the sample size. Is it large enough to give us reliable results?
And they should definitely pay attention to those p-values and confidence intervals.
Yes.
A statistically significant result with a narrow confidence interval around a clinically meaningful effect would be pretty impressive.
Absolutely. But even then, it's crucial to consider those potential confounding variables and think critically about whether the findings are truly applicable to their specific patients.
So it's like being a detective. We need to examine all the evidence before reaching a verdict.
Well said. Now let's shift gears a bit and talk about another area where biostatistics plays a crucial role: risk assessment and prediction. By analyzing huge data sets, we can pinpoint factors that increase a person's risk for developing certain diseases.
So it's like using data to create those personalized risk profiles you see advertised online.
It's similar, but on a much larger and more sophisticated scale. For example, by analyzing data on factors like age, family history, lifestyle choices, and genetic markers, we can identify individuals who are at higher risk for developing conditions like heart disease, diabetes, or certain types of cancer.
That's pretty amazing. But what do we do with that information? It seems like it could be a bit overwhelming to know you're at higher risk for something, but not necessarily know what to do about it.
That's where preventative medicine comes in.
Okay.
By identifying those at higher risk, we can target screenings, recommend lifestyle modifications, or even prescribe medications proactively to reduce their chances of developing the disease.
So it's like we're moving from a reactive approach, waiting for people to get sick, and then treating them, to a more proactive approach, trying to prevent illness in the first place.
Precisely.
Yeah.
And this is just one example of how biostatistics is helping us move toward a more personalized approach to healthcare.
Okay.
By analyzing all this data, we can tailor treatments and interventions to individual patients based on their unique characteristics and risk factors.
That's incredible. It seems like biostatistics is no longer just a behind-the-scenes number-crunching field. It's becoming increasingly central to how we deliver and receive healthcare.
I completely agree. And as technology advances and our ability to gather and analyze data expands, the role of biostatistics will only continue to grow.
It's exciting to think about all the possibilities. This deep dive has truly opened my eyes to the power and potential of biostatistics in medicine. It's a field that can seem intimidating at first, but with a little effort, anyone can grasp the basic concepts and start using those tools to make more informed decisions.
Absolutely. And remember, you don't have to be a statistician to appreciate the impact of data in healthcare. Just being aware of the key concepts we've discussed today can empower you to ask the right questions, evaluate evidence critically, and engage in more meaningful conversations about your health.
This deep dive has been an incredible journey, and I hope our listeners feel empowered to embrace the world of data in healthcare.
Me too. The more we understand about how data is used, the better equipped we are to navigate this complex and ever-evolving landscape.
Until next time, stay curious, stay informed, and keep those deep dives coming.